Hey everybody, it's Karen Anderson here with our week in review, and I was just gone in the wonderful city, Edinburgh, Scotland, and of course, I come back with a cold because I wouldn't have it any other way. I think it adds depth and tone, and it's fun to listen to me cough and have sneezy nose and stuffly nose. So bear with me, please. I'm not trying to be disgusting. It just is what it is. But before we get started talking about last week's incredible information for Aortic Disease Awareness Month, I need you to click the like button, and I need you to click the subscribe, and I need you to click the bell so that you're notified every time we go live. Now, for those of you watching, tonight's live event with Dr. Tyler Wallen has been moved to October 1st, okay? But we do have a live event coming up tomorrow with Rosie Paulson, who's going to talk to everyone about Medicare. Since Medicare open enrollment is coming up soon, it can be very challenging, the rules, the policies, like, do I get a Part B? Do I get a B supplement? What does it all mean? And so she's going to do a great job just kind of teaching us what that means for those of you that have Medicare and you're going to be thinking about making a change, or you've just been accepted into disability and you're going to take the Medicare, whatever the thing may be. But that's going to be a first for us. So you definitely want to have that bell clicked so that you'll find out when these live events happen, beyond just knowing about them underneath of our event section on Facebook, as well as our website. All right, so we're going to get started. Before we get started, you got to chat to win. If you chat with us today, we're going to keep a record of those names. We're going to randomly select 5 people today, and you'll get your choice of a card decal or a magnet. Okay. If you just want a bracelet too, the choice is yours, whatever, if you've gotten those other items before. But because it's Aortic Disease Awareness Month, any chance we have to be able to give you swag, to be able to create that awareness in the community, we are happy to do so. All right. We're going to start off with what occurred last Monday, and that was a post about aortic valve disease. And the reason is because last week was heart valve disease awareness week. Okay. It gets really confusing because it also, for some organizations, they like to focus and make it be Aortic Dissection Awareness Week. And then there's Aortic Dissection Awareness Day. There is no Aortic Disease Awareness Day. I'm seeing these things pop up. Look, there can be, but there really kind of isn't. But it is known around the world, September 19th, as Aortic Dissection Awareness Day. That happened many, many years ago. Then some people decided to focus on that for this week. We made a change many, many, many years ago to have it be Aortic Disease Awareness Month, because the disease element of dissections is very different than the precursors we're hoping to diagnose to avoid a dissection. So there's so much information we cannot possibly share it with you in just one day, let alone 1 week. So we take a whole month. So let's get into aortic valve disease. So this was written by Adam. And as he mentions, we've been showing a lot of the aorta. Loving this campaign. But one thing we hadn't really touched upon in depth up until last Monday was the beloved aortic valve. This is one of 4 valves within your heart. And the aortic valve is actually the gatekeeper between the heart and the rest of the body. It's the final valve, the last valve that opens, and the blood will then enter the aorta. All of that oxygenated blood, it has gone around the 4 chambers of the heart, and now it's coming into the aorta to be distributed through the body. So most normal in quotes, aortic valves are tri-leaflet. Kind of looks like the Mercedes-Benz logo. So it's got 3 cusps, little areas that come together, and with each of these heartbeats, the leaflets of the aortic valve should open together in unison and really allows blood to flow from the heart, and then it tightly seals back together again, and it prevents blood from flowing back into the heart or leaking back in. This is where your aortic valve is located in the heart, because this is the aorta, right? See, we've got our 3 branches, and so it's located right here. It's right there. This is what a normal aortic valve will look like with its 3 leaflets. Okay, 1, 2, 3. Now, aortic stenosis, which is one of the aortic valve diseases, is when it's too tight. It's when those leaflets are just too tight. It gets kind of rigid. And over time, as we age, several deposits of calcium, fat, cholesterol, they can build up on the leaflets of the aortic valve, and that actually can cause it to harden, just like it can in your vessels when you have hardening of the vessels. That can lead to heart attacks. Okay, this can lead to hardening and stiffening of the aortic valve, and it really kind of loses its ability to maximally expand. And as a result, the pressure needed by the heart walls to pump through this small opening, it actually increases. And the heart has to end up working harder with each beat to force that blood out of into the aorta. So here's a good example of this area right here of your aortic valve. Here's what a normal open aortic valve looks like, and here's what it looks like when it's closed, right? And this is what it looks like when you have stenosis, and this is what it looks like when it's closed. So it's not coming together fully, right? Now, the symptoms of having aortic valve stenosis can include shortness of breath, unexplained tiredness, and in some severe cases, dizziness or fainting with heavy activity. So this dizziness usually occurs due to a decrease of blood reaching your brain from the tightness of the valve. I'm not a physician. I didn't write this. Our medical student, Adam, did, but I'm just relaying the information. Just want to throw that in there. All right, risk factors for aortic stenosis include things such as older age, high body fat content, elevated cholesterol, genetics, and smoking. Smoking will always be a risk factor for aortic disease in general, but specifically here we're talking about aortic valve stenosis. Okay, that's one disease element. Now let's go into a second. This is aortic regurgitation, just like the name sounds, regurgitation. It's going to be backflow. And it's the opposite problem of stenosis. The problem is that the valve is not tight enough, and it really allows blood to actually leak backwards into the heart with each beat due to an inadequate seal that happens between the leaflets. It kind of gets floppy. And in a normal heart, the blood should always flow in the same direction after it leaves the aorta. But in patients with aortic regurgitation, the blood is pumped out into the aorta, and some of that blood actually flows back into the left ventricle as blood is pumped out of the aorta. So while the heart can compensate for this short term by beating harder to pump extra volume over time, this is actually going to exhaust the walls of the heart, causing it to dilate and weaken. Okay. So here's another example. Here's your aortic valve. That's your left ventricle. That's your right ventricle. And here is a weakened aortic valve. Here's a cross-section view of that. And you can see that cusp of the valve, the one on the far left, is floppy looking. It's not going to close tightly with the other two cusps, allowing regurgitation or backflow back into the left ventricle of the heart, that left chamber. Symptoms of regurgitation might be similar to aortic stenosis in that it can include things such as shortness of breath, tiredness, fatigue, especially with physical activity. And risk factors for aortic regurgitation also include old age and things like prior infections of the aortic valve and connective tissue disorders. Those things can actually cause regurgitation. Okay, let's talk about another one that is probably common, except this is something congenital because it's what you're born with. The other two can develop over time. This particular one you are born with, and that would be bicuspid aortic valve, or BAV, as those initials are found in the community. And it's estimated that 1% to 2% of the world's population have bicuspid aortic valves. And it's not something you're going to know about unless you happen to have an echo for probably some other reason, or you're feeling some kinds of symptoms, and it's going to happen through a test, echo or CT or MRI. But people with bicuspid valve will actually develop aortic stenosis or regurgitation much younger in life. So this is not something that's going to affect them when they're older. They have that chance of developing stenosis or regurgitation younger in life, like 40s and 60s versus 70s and 80s. And that's due to earlier deterioration. I cannot talk today because my throat hurts. Earlier deterioration of the leaflets. So in addition to an elevated risk of premature valvular stenosis or regurgitation, there's some research to suggest that patients with bicuspid aortic valves have an elevated risk of developing a weakness in the aortic root and the walls. What is a weakness in an aortic wall? An aneurysm, and that's what it will lead to. It could lead to an ascending aortic aneurysm and or possibly a thoracic dissection over time. Okay, cross-section view again, aortic valve right here. This is what it normally looks like. You have your 3 leaflets. Here's what a bicuspid looks like. There's only 2. Something happened in the development of this person that it didn't create the 3rd one right there. Just happens. And would you believe there are people that are actually born with 4 leaflets or 1 leaflet? It's a little bit rarer, but it's amazing that you can have just, what do you even do with 1 leaflet? I'm not even sure. I guess it just springs off the wall. I don't know. I don't think I've seen an uno leaflet or uno cusp. I don't know. I don't even know how you pronounce it. But you can be born with 1, 2, preferably 3 or 4. It's just if you're not going to have 3, 2 tends to be the most next common issue with the aorta. How do you diagnose? So if it's suspected that you have any kind of aortic valve disease, then your doctor is going to order a test called an echocardiography, or echo for short. That is just an ultrasound. It is very simple. It is just a wand that gets rolled around on your chest, hopefully with warm jelly. That's what happens. You lay on your side, or you may lay on your back. Takes about a half hour, non-invasive. You won't realize what you're really looking at on the screen. It's easy peasy. They'll be able to check out a lot when it comes to your heart and your heart functions. And the echo actually gives the doctors a lot of valuable information, including a visual representation of how strong your heart muscle is, how it's contracting, how the blood flow is, as well as detailed information about the pressure and volume measurements with each of your heart chambers, which can be used to grade how severe the stenosis or the regurgitation is. It could be mild, it could be moderate, it could be mild to moderate, severe, or trace. Oh, everybody, not everybody, because I do not know, I don't want to make a statement like that. Many people, when they have an echo, the results could come back that say trace regurgitation in the pulmonary artery. That is not something to freak out about. Trace in the mitral valve. Pulmonary valve. It's not something to freak out about, okay? Trace regurgitation or stenosis in the aortic valve, it's trace. And the interesting thing that I believe I was told about aortic valves is if, let's say, you have regurgitation and it's been trace, and then all of a sudden you go back 1 month and it's mild. You go back 6 months later, it's now trace. The valves change with blood pressure issues. So it can be trace. It can go up to moderate. It can go back down to mild. I would think that when it stays at one, indicator, whether it's mild or moderate, that then becomes what you're dealing with. Something has now actually changed. But try not to freak out when something says, oh, we found trace regurgitation. If your doctor's not freaking out, then don't freak out. Ask them to explain it to you. I think it'll make you feel better once you understood. Excuse me so much. That was my dog barking. All right. While mild to moderate disease can be monitored over time with repeat echocardiography and controlling risk factors as controlling your blood pressure and stopping smoking, once the threshold for severe aortic stenosis or regurgitation is met, the only treatment that's known to prolong life expectancy and improve those symptoms is going to be an aortic valve replacement. So here is a picture of someone having their echo done. Your heart is right about here. You're going to have electrodes that's monitoring your heartbeat, and that's the probe. It just rolls it around the chest. You are not going to be able to see the screen if you're laying on your left side. So you hope to find someone that's left-handed and they're on the other side of the table. But you lie on the left side. The sonographer moves the transducer on the chest. The EKG patches are on you to monitor your heart rate, and the computer records everything. So that's it for Monday's post, all about aortic valve disease to get us set up for the week of aortic valve disease awareness. All right. That was that way. That was that day. Good stuff. Have anybody we need to say hi to?
Well, let's say hi to quite a few people, and I have a story.
Okay.
Tom, Christina, Molly, Velda, what is up, everyone? So Velda hasn't gotten the link yet. We were just talking about that before the show started. And Christina has been having some of the worst luck with a truck right now. So she's been in and out of the shop here over the last couple weeks.
Wow.
This last stop in, she was wearing her Aortic Hope shirt,
Uh-huh.
and obviously in the truck on the seatbelt is her seatbelt cover. So she gets in, and the mechanic starts asking questions about a two-leaf valve and aneurysm. And she knew that
Hmm.
she was a dissection survivor. She saw everything about what she was wearing the seatbelt cover, and was surprised that aneurysm and dissections are both a result from an aortic dissection. So she's dealing with her loved one having heart surgery soon to replace aortic
Wow.
valve and fix an aneurysm.
Yeah.
Right?
Yeah. How lucky that person is. Wow. Right. You
Right?
want to applaud that situation.
That's amazing. So
That is
she
great.
was like, "It's a good thing. I got her all the info she's been looking for. Told her to request the booklet or download the free download and
Hmm.
sent her the link." That's so
That's
awesome.
awesome.
She says the
So
truck's been a
awesome.
problem for months.
Oi. Oi. I
Valda, I
hate when
need
that
you to put
happens.
into chats who you were on the radio with, because
Yes.
we're gonna call them out from YouTube. We're gonna start the war.
Yeah.
I want
Yep.
my Velda spot. Okay, carry on.
Yeah, we love when the community has an opportunity to do stuff like that. That's amazing. I need to get you our little 20-second time on the TV, Terry and I, for Good Morning Maryland. That was our big shout out. And let's see what else. And then we're going to get, we had Nicole videotaped the speech that Ben and I gave at the Aortic Dissection Awareness UK and Ireland September 19th day that we were in Scotland for. She videotaped the whole thing. We're going to get that online for you guys too. Just us, nobody else. We kind of went over our 15 minutes, but it was great. I mean, we nailed it. It was so good. Great stuff. Can't wait for you to see it. All right, we're moving on. Speaking of Ben, Maimonides Aortic Center, in association with Aortic Hope and Aortic Bridge, we are all recruiting patients right now. So they are again, they've been doing this for quite a few years now, requesting to have patients talk about the psychological impact of aortic dissection, aortic aneurysm on the survivors in our community. They're really looking to this study, and if you've participated in this anonymous survey, please do so again. And let me tell you personally, I've participated every year it's come out. And over the years, myself, I have seen how things have changed for me psychologically over the years in relationship to my answers. Because I remember, all of a sudden, I remember, oh gosh, I remember feeling a lot worse when I answered it 2 years ago, 3 years ago. So I encourage you to do that if for no other reason than to just see for yourself, gauge, how you might be feeling. But the other reason is Maimonides, which is where Dr. Ben Udelman is out of, is actually very committed to enhancing care for those that have been impacted by aortic disease. And your insights are really so invaluable to them. I'm going to sneeze. Just bear with me. Phew. Okay. Ugh. Ugh. Okay. Ugh. Where was I? Yes, invaluable, is what I was saying. Whether you're a patient or you have family health history of aortic disease, they're inviting you to please participate in this very brief anonymous survey. And the survey is part of a multi-year study aimed at refining care for those affected by aortic disease. And your feedback is actually going to help them better understand the impact of our diagnosis and what it has on our mental health and quality of life, guiding them in improving treatment and services. And there's a link here for you to take it. It can take anywhere from 5 to 15 minutes. It's really up to how you answer questions and how you feel. But your anonymous answers will really help them tremendously in gaining a better understanding of your experience and for the development of a more comprehensive care going forward. This is not care that we're seeing in every single aortic center. I mean, the dreamy goal that I would love to see in 5 years or less is that when we're discharged from a hospital, whether we have, let's just start with dissections. You've had a surgery, you've gotten your patient guide. When you're done, when you're discharged, we also have been told go see your primary care within the next month, guest schedule with your cardiologist, schedule your follow-up care with your surgeon. But there's no mention within the next 1 to 3 months of seeing a social worker which would be the representative from the hospital. They should be visiting you. You have home healthcare nurse that comes by probably. You may or may not be scheduled for rehab, and if you're not, you should go to physical therapy. They should be more than happy to give you a script for that. But where's the follow-up with a social worker? Because so many of us don't know that we're experiencing any kind of mental health trauma or post-traumatic stress disorder. We're not going to know that in 5 days after being discharged. It takes time. As your body's healing, the brain then starts to show itself a little bit more. And I also think it's extremely important that patients should be required to have a meeting with a representative from a patient-led organization like Aortic Hope. And they can do that by attending a support group meeting or meeting somebody, and whether it's in person locally at their hospital or accepting a Zoom call or, a Teams call or phone call, because I feel, this is just me, tell me if I'm crazy, I feel that given the opportunity to meet someone just like them and know that they're functioning, that they're living life to their fullest despite any challenges that may happen, that they have that same opportunity. Because as you all know, when we come out of this, we don't think. We don't even know what's really happened. And I feel the same way for those that are being diagnosed with an aneurysm and they're in this watch and wait. They know that they were feeling something, or maybe they were feeling nothing, but all I know is they've gotten this diagnosis and they feel a lot. They all of a sudden feel very symptomatic. Some of them still might not feel symptomatic, but most of them are coming away feeling scared. What can I or can I not do? What are these restrictions? All of a sudden, my life's been upended. Am I going to have a dissection or a rupture and drop dead? That's what they're feeling. And I think that they should also be required to speak with a social worker, a therapist, and a patient care representative in the community. I think it will help them feel more grounded and learn a little bit more with accurate information that is presented to us from physicians that can then be shared with them. That's my soapbox. I've just stepped off a bit, but that's what I think. And this is what I think this study is really going to help them realize the impact. And what they have come to realize already in some of their stats is how the type B dissection community has more accounts of PTSD than type A. And I think, it's not that I think, it's what I was told at this event that we were at. It's because they're only medically managed and they don't know when their surgery might happen. They don't know. You're just watching constantly and waiting. It's a different type of watch and wait. So that's some of the stuff that they're learning. And then hopefully that paper gets published and then physicians start reading that and adapting some changes. So that's where your anonymous survey answers come in really handy. So please give it some consideration. And that's that, Jack.
All right. So on to the war effort here.
Okay.
Mitch Cormier on Island Morning, CBC Radio 96.1. We want our link.
Yes. Okay.
I told Velda I would liberate PEI from Canadian rule if I have to.
All right. Sounds like a plan. You get on that. Let me know how that works. All right. We're moving on. So World Health Organization always has a patient safety day every year. I'm not too sure how many of you were aware of this. It happens just like a day or two before Aortic Dissection Awareness Day. And this year they were focused on improving patient safety by reducing errors and minimizing harm in healthcare settings. And they actually have a theme, which they have a theme every day. Let's get to this, but let's talk about it again a little bit more. So World Patient Safety Day is an opportunity to raise public awareness and foster collaboration between patients, healthcare workers, policymakers, and healthcare leaders to ensure and improve patient safety. This year's theme was improving diagnosis for patient safety with the slogan, get it right, make it safe. And I kind of dig the slogan. And the idea was they wanted to highlight the critical importance of correct and timely diagnosis in ensuring patient safety and improving health outcomes. A diagnosis identifies a patient's health problem and is a key to accessing. I just went through something sounded wrong. Accessing still doesn't sound right. Now I've said it too many times, so it doesn't mean anything. It's the key to making accessible the care and treatment they need. A diagnostic error is the failure to establish a correct and timely explanation of a patient's health problem, which can include delayed, incorrect, or misdiagnosis, or failure to communicate that explanation to the patient. So there was an opportunity for you to click on a link here and take a moment to listen to Tammy Warner. She is one of our board members. She is a director of community services, and she was telling her story of survival, or the computer was reading her written story of survival. But her story actually highlights global patient safety issue of misdiagnosis and delay in acute aortic dissection, which the patient-led Think Aorta campaign is addressing. Tammy's emotional and inspiring story really defines this year's Get It Right, Make It Safe campaign. And I implore you to go ahead and take a read and take a listen, but because aortic dissection is a life-threatening condition, and that involves a tear in the body's biggest artery, the aorta, which carries blood from the heart to the brain, limbs, and vital organs. And World Patient Safety Day from World Health Organization is an annual event that emphasizes the importance of patient safety and encourages open dialogue between patients and healthcare providers, and it aims to reduce the risks associated with healthcare by promoting awareness, accountability, and effective communication in healthcare systems. All right, that is World Health Organization Patient Safety Day. So check it out. Okay.
You did a really good job.
Thank you. That was the boost I needed, because I feel like I'm failing. Trying. Have you signed up for Hope Mail? Did you know that Hope Mail started with 4 knitted heart pillows that I made to give as gifts for people? 'Cause I was learning how to knit and I didn't know what I was doing. And now we have over 300 patients and caregivers receiving a once-a-year acknowledgement, little small care package from us that basically says thank you for your support, and we hear you and we see you, and happy aortiversary. There's an idea of some of the things we've sent out. Jar openers, so handy, right? Journal books, so handy. This year, we had a request, well, from last year, to address mental health issues in a different, unique way. So this year's Hope Mail packages are actually full-size 8.5 by 11. It's not a coloring book. What is it? It's like not a mandala. It's a coloring book, okay? And it basically has affirmations, but it's geared towards an adult. And we also included 4 or 5 pencils, colored pencils, as well as a calming strip that you can put by your computer mouse or on the back of your phone, and you're supposed to just kind of rub it and it makes you feel calmer. I find it very irritable. I don't like it. I've tried it, but many people say they love it, and I'm going to sneeze again. So, okay, here we go. Oh, okay. All right, so this is free. This is a free initiative for all of you. And if you sign up, you're going to receive once a year. So I know so many of you have so many surgery dates. Pick one. Pick a favorite date. I can't give away 2. I can only give away 1. And that's going to show you our appreciation. So whether you have an aneurysm, if you've had a dissection, I don't care if you even haven't had surgery. If you have an aneurysm, that's your diagnosis date. Put that down as your date. If you want to change that date, then just send us an email and we'll make some switches, but you might as well just leave it. It really doesn't matter. But just date of diagnosis is fine, or date of surgery. It's free. Sign up and start getting your Hope Mail. Now, the key is if you sign up like right now in September, you're not going to get Hope Mail till next September, because we send everything out no later than the 15th of the month. So if you sign up after the 15th, you have to wait till next year. And if we send something out to you and it bounces back and it is not the right address, you will be deleted, because we get too many things that come back to us. Now, if you send us an email that you've moved or something's changed, we will update that and make sure it gets to you. But obviously, if there's some error on our behalf, we will be glad to send it to you. Those of you in the EU, you have messed up mailing system. What's going on? We have been told that you have to pay for your packages. So we have to talk about that, okay? We're looking into seeing if we can get something that isn't a package, that's flat and can go in an envelope. It's just so you can get something from us. So if you haven't gotten something, it's because we've had too many turned down and sent back to us, and it's very costly. But we will look into something for you. Otherwise, if you're from Canada, what have you, we're sending it out. So that's Hope Mail. Okay, we're back to aortic valves. We're going to talk about aortic valve replacement. We talked about the disease, and now we're going to talk about the way that some of the valves fail over time. What's it called when an aortic valve becomes too tight? Anybody? Any takers?
They're going to be on a delay.
I know. That's why I'm waiting patiently. What's it called? I'm not blowing my nose. I'm just going to dab it very daintily. Aortic valve. Tight. It's a good question. I'll keep going.
Hum that Jeopardy thing.
Do 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 do. You're gonna call me a nerd. Do 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 do.
Molly says
yes,
stenosis.
Molly. That's right. Yay, Molly. Good. You just wanted me to stop singing. All right, we're going to shift gears. Let's talk about how doctors can help treat aortic valves. So with mild and moderate disease, as we mentioned, it's monitored over time through echocardiography and controlling risk factors such as high blood pressure, getting rid of smoking. And once the threshold for severe aortic stenosis or regurgitation is met, we now know that the only way to prolong life expectancy and improve symptoms is with a valve replacement. Valve selection. This is so key critical. And I will tell you, for me, I know I had my valve resuspended, which kind of means tightened up. They did whatever, they kept my valve. That's all I know. When I had my dissection, but my valve is not liking me anymore. It's not playing nicely. And I have moderate regurgitation or moderate AI, aortic insufficiency. So I'm probably going to need to have my valve replaced. So this is like a constant reminder, and I'm constantly looking at the latest and greatest that I find out there in the world, because I'm not 100% on these choices that we have here. A lot of pros and cons, very personal decision. But when you're going to undergo aortic valve replacement, one of the primary considerations you and your doctor will make is whether to receive a mechanical or bioprosthetic valve. So each of them offers unique benefits and some drawbacks. A mechanical valve is the most durable, pending any potential infection, because everything in life has that potential, right? It's the longest lasting valve, often pumps for 20 to 30 years before it might even start to wear down. It is the primary choice for younger patients. It's going to really get you through a lot of your lifespan. Okay, so that's why they tend to want to go with something that's mechanical. Here's a good look at what a mechanical looks like. Here it is where your aortic valve would be. Nothing tissue looking like it, but it does have, I don't even know if this looks like, it's not 3 cusps, right? But somehow it does the job. But it's mechanical. And once it starts ticking, it just keeps going, right? The main drawback of that mechanical valve is that they're more likely to cause small blood clots. So, and that can increase your risk of stroke or heart attack. Therefore, patients will require lifelong blood thinners such as Coumadin, or otherwise known as warfarin. All right, and then you're going to have to get a regular blood test. Sometimes these patients are now testing their blood at home, I believe, on their own monitor, and that's checking that the thickness of the blood is within safe range. We don't want it too thin, right? So in addition, some of these patients might, they've actually reported hearing a clicking sound, like the tick-tock of a watch. And that's when the sound of the valve opens and closes, which takes some time to get used to. Both of those things make me scared that I will lose my mind. And it's not like you can just say, I don't like it, please take it out. The other thing you have to think about is with a mechanical, it cannot be put into you endovascularly because they don't smush, they don't fold on themselves. Okay, so you need to have open heart surgery as of today. Things are changing. Let me tell you, I was at this conference. There are so many incredible new things on the horizon. So you don't know if things will change in a few years, right? But if you chose a bioprosthetic valve, these are made from using tissues of either a cow, which is bovine, or a pig, which is, I think it's called porcine. I don't think it's porcine. Although porcine sounds like it would make more sense, but yeah, it is a pig valve. And I don't think you get to choose which one goes into your body, because I believe it's, the hospital makes those decisions on what they have. Plus, it's all a matter of what would work best with your body. There's so many things go into that decision. I don't think you can walk in there and say, well, I would like a tissue valve and I would specifically like it to be, I don't think you get to make all those choices. But those valves in and of itself, because they're bioprosthetic, they have a much lower risk of thrombosis or blood clotting. And most patients do not have to be on lifelong blood thinners. However, unlike the mechanical counterparts, the bioprosthetic valves are much more susceptible to a calcium buildup. And over time, it can lead to premature structural valve deterioration. So they may only last 10 to 15 years, right? So this is a bioprosthetic valve. It kind of looks like tissue. The interesting thing is this is not like we took a cow valve out of a cow and put their valve in your heart. That's not how it's done. I only know that tidbit. I don't know anything else. We'll read if that was put into this post, but this is not an actual cow valve. This is, you can see this material that actually gets attached to your aorta in that area. That's not from a cow. All right. So their durability actually goes 10 to 20 years, which may not be an issue in elderly patients, whose life expectancy is within this range. But however, younger patients who undergo bioprosthetic valve replacement and outlive their valve will need a second valve replacement in their lifetime. Now we're going to get into the two different ways in which you can have this procedure done. So it's SAVR, traditional surgical aortic valve replacement. We don't talk about this acronym a lot. We just say open heart. But that is your surgical aortic valve replacement. The only way to get in there, surgery, is through the open heart surgery. And they're going to remove the diseased valve and replace it with the bioprosthetic or the mechanical, and it takes over the function. So gazillion stitches and wires and stuff, and they basically just thread it right down into place. That looks like it is bioprosthetic. Okay? The benefits of doing it open or SAVR is that it allows for direct visualization of the valve and all of that surrounding tissue, so they can see if there's any damage to anything because they're already in. And they can cut out any diseased tissue, any calcium deposits, anything, before actually suturing a new valve in place. So it's kind of like, it reminds me of everybody who gets nervous about having a colonoscopy, and they choose to do the camera, the capsule pill, which takes pictures. That's all well and good, but if you've got a big polyp, they're going to have to go back and do surgery anyway, so why not just go in and do a colonoscopy, and if they see something, they can take it right out. You're just taking care of anything that you see because you have it open and you're in there. Excuse me. So patients that have both aortic valve disease and aortic vessel disease, meaning let's say you have a bicuspid valve and you have an ascending aneurysm, surgery will allow you to fix everything at one time. The last thing you want is to have two separate surgeries. So it gives them a better opportunity to actually visualize everything and determine, should we just do everything at once while we're there? But we know that open heart surgery comes with the risk, because it's an invasive operation requiring patients to take off anywhere from 1 to 3 months to recover from work. Those of you who have had a dissection, you know what this is like. You know what it's going to feel like to have your chest cut open and tubes and wires, and it's hard. It's a tough surgery. But again, it's going to give you a lot of visualization from your surgeon. Alternatively, there have been several advancements have been made in transcatheter aortic valve replacement, or TAVR, transcatheter aortic valve replacement. So in this procedure, either an interventional cardiologist or surgeon will make a small cut in your groin, in your shoulder, or your neck, and they will actually deliver a guide wire through the peripheral artery into the aorta under radiological imaging. It's very cool. See? It's coming all the way up here. Boop. Then it deploys it. That to me looks like it's mechanical, but it couldn't be because it's endovascular, so it's definitely tissue. A compressed prosthetic valve, bioprosthetic valve, will then be looped over the guide wire to the portion of the aortic valve and expanded to take over function of the diseased valve. So they're not actually cutting out the valve. It's just going in and opening up like an umbrella, and it takes over. It spreads it apart, and boom, incredible. It takes 45 minutes to an hour and a half, 4 to 5 hours on average for an open procedure. And patients might spend like 1 to 2 days in the hospital, returning to work shortly thereafter. I've had stuff up the groin. It's a little uncomfortable, but it doesn't wipe you out like having open, right? But here's some of the drawbacks of a TAVR. Elevated risk of putting in a missized valve. That would not be pleasant, right? Or the bioprosthetic, there's a mismatch going on, and the need for a permanent pacemaker, as delivery of the wire and valve may cause damage to the native electrical conduction system of the heart. So additionally, patients will need peripheral arteries large enough to allow passage of the wire and the catheters without damaging the native vessels. When you are sitting there deciding between open SAVR, which is surgical aortic valve replacement, or endovascular, which is TAVR, your doctor's going to help you consider various risk factors, including your age, other additional risk factors, and your anatomy. Older patients, meaning people over 75 years old with several comorbidities, tend to be offered TAVR over surgical. It's less physically demanding, and the results in a faster recovery. It's worth noting that all currently FDA-approved TAVR valves use a bioprosthetic frame. Okay, which means they're subject to structural valve deterioration over time. So if you're going to go endovascular, it must be prosthetic, bioprosthetic. So you're talking cow or pig, because it can bend and go up the guide wire. You can do either or, those or mechanical when you're cut open. Okay. Younger patients, anybody who's 65 or younger, who can physically tolerate open heart surgery, tend to want to have open versus endovascularly, because the use of open in this population also gives patients the option of receiving a mechanical valve, which might be beneficial given the longer life expectancy of the valve. And for patients with other anatomical or disease risk factors, such as bicuspid valve, or I don't know, concomitant, don't know what that is, or what it means, what issues with your aortic root, or coronary artery disease, having a surgical replacement may be preferred. It's a lot of things to talk about. You know, I went into my doctor and I asked him, if I were your sister, you know, your daughter, even though we're like the same age, what would you tell me to do? And the preference has been to do mechanical. It's kind of like at 55, I probably could be close to a one and done. The problem is when you have a mechanical, I don't think you can put a bioprosthetic over top of mechanical. So I'm still, you know, young enough, you know, to be able to have, I guess, to have that, but I also have an aneurysm, so why not do surgical? I mean, if it needs to be replaced in 10 or 15 years, you can actually deploy another valve through the groin again. It will just deploy right on top of it. So you're looking at 20 to 30 years. I'm probably not going to be here in 30 years. I'd like to think I would be 85, but I don't know, you know? And at 85 or 90, I don't know how much I'm going to want to jump into having my heart, my chest cut open. I don't know what. But I'm just hoping to hold off for a few more years until the next great invention occurs, right? That's all we're trying to do. But it's a lot of things, right? It's like, do I want tissue that could go bad sooner? Do I want mechanical that's going to go tick tock, tick tock, tick tock? And I love all the people out there that say, I don't even hear it. It to be mine. I will hear mine. It will make me nuts. And the whole blood thinner part, I don't, so much. A lot to think about. A lot of research. And our second book, Aortic Disease, the Patient Guide, really addresses a lot of this from patient to patient. And hopefully we'll reiterate this in much more detailed fashion, but easy to read, and help you, you know, with your decision making, because this is tough. It's a hard decision. And for a lot of us, it's very necessary, and you need to kind of think about it. So that was aortic valve replacement. All right.
Well, well,
We're moving on.
well, well.
Walla balla balla.
There's all kinds of chit chat going on today.
Oh, what is it?
So Molly wanted to chime in about the mechanical. She was like, "Mechanical!" Exclamation points abound. Coumadin is not an issue. The clicking is minimal.
Oh, I know. Uh, hmm.
Okay, well,
But you can't even take Advil with a blood thinner, right? Like you're stuck to just a Tylenol, which is like consuming a TikTok. I mean, a Tic Tac. I don't know. I have to think about it.
and
I'll be
then
coming to the community to ask anyway, I'm sure.
yeah. And then both Molly and Christina checked their INR at home. Molly said testing at home is easy and reasonably priced, and Christina was like, "I check INR at home too." And so once again, she's like, "One and done." Molly over here.
I
No,
know.
thank you for having another surgery to replace the tissue valve, even if it's endovascular. One and done is my choice.
What if my doctor gives me one that's really loud TikToker? Just, I'm telling you, it's a risk that could very well happen to me. So, I don't know. Hopefully, I have time to think about it.
All
So,
right. Well, so let me see here. Christina, she says she didn't get a valve replacement, but she's got an IVC filter that was forgotten to take out.
what?
Right? And so Molly goes, I'm surprised Christina doesn't have a bovine. And then she put a bunch of smiley face emojis in there.
I'm surprised Christina doesn't like have $1 billion and
Right?
have the hospital named after her.
So she says, my own valves are good. The metal filter I got, it was to stop blood clots going through to the heart and lungs. So blood vessels are different than the aorta, not the aorta. Right? So then
Wow.
both me and Molly were both like, oh, gotcha. And then Christina
Okay.
says, but of course, Molly, dairy people choose to have a cow valve over a pig. Cow
Why?
people, because they trust cows.
Oh, sure.
So Tom
I don't know.
says,
And then I have to wonder, like, do Jewish people have to worry about having pig valve over cow? I mean, I don't keep kosher, but I have to ask the question. Like, that's just popped into my head. Or do they not think about it? Because it's just, I don't know. I'm going to ask somebody that's higher up the food chain in the religious world and see.
right on. That's a
Yeah,
safe bet.
yeah,
So Tom
curious.
says, I have a Watchman in line with heart, 2 years old, no problem. Now I may be drawing a blank, but I don't remember what a Watchman is.
A Watchman, my father had a Watchman.
Okay.
I did not contribute to anything. A Watchman, Ben Udelman described as it's kind of like a clip. It's a procedure in that is supposed to, it won't take away AFib, but it takes away the risk of developing a stroke or having blood clots because it kind of stops that heart from doing all the jiggling and twitching, and then the patient can go off of Eliquis. So it doesn't cure AFib, but it puts you in a situation where if the AFib happens, it doesn't last long enough that, when you sit and have the heart twitch like this in AFib, there's going to be a corner or someplace where blood might pool because it doesn't get the normal pump to push it out. But then all of a sudden it may do a big pump and it could have had a clot. But it doesn't take long for blood platelets to clot, right? And if it's just sitting there like, I don't know what's happening, I don't know if I should move, it may clot. And so that's why they're put on blood thinners, because you want to avoid the stroke issue. So I believe that the Watchman is a device that would keep you from needing to be on that blood thinner, like that Eliquis, the heavy ones.
Okay.
I think. I'm
Yeah.
not a doctor.
Okay. So Brenny says Sony Watchman cassette player. So hey John.
Hey, John.
Molly wants to chime in. She was told the tissue valves tend to wear out quicker the younger you are.
Well, they just wear out. I know people that have had their got it at, let's say, age 37, and they're in 15 years, still haven't. It's working just fine. No issues with stenosis or regurgitation. It's doing great. In 15 years is, now you're starting to push it. But if there's no signs of that it's wearing out and everything's numbers are coming out fine, they keep it in. It's not like it just stops. like whoop, turns off. There'll be signs that things are starting to deteriorate. But yeah, no, there are people who got it. And I mean, I look at, younger being mid to late 30s. So I think everybody must be different. And now I would like to think that the products coming out nowadays are even better. I don't know. I touch them all the time at the conferences. My next conference, I'm really hoping that I can put on some gloves and like try to pretend I'm sewing it in like a vessel. Oh, God, I'd be so excited if I could try that.
That sounds
That would be
fun.
really fun.
Yeah.
So fun, right? Get a little bit of residual blood, kind of like I want to feel it squish. Anyway, okay.
All right.
All right.
So Tom was acknowledging John, saying, "That's right. Give this man a prize."
Yep.
Rob has joined the chat. He says
Hey, Rob.
medical devices are not subject to kosher laws.
Thank you.
Thank you,
That's
Rob.
good to know him. Very good.
And
That's good.
also, Tom says it is a blood filter. AFib control is a side effect.
Right. Yeah. Yep. Watchman has been around for a while and does very well for people. I think that would be used first before, or maybe, well, they didn't do an ablation on him first. They went right to Watchman first. And I guess if that doesn't work for whatever reason, then they could do an ablation. An electrophysiologist is usually the one who would do ablations. They find the area where the electrical impulses or pulses, misfiring happened, and they just burn it on the inside or the outside, something like that. Yeah.
Christina says, I sure hope not. Got IVC filter in May 2014.
Okay. Weird. I know people have had those filters put in like near their groin because they had leg blood clots, but I didn't know it went into near your heart like that. Interesting. God, these community members have such interesting things. All right. Going on to September 19th, Aortic Dissection Awareness Day. Let's talk about aortic dissections. Small challenge without peeking. What are the 3 layers of the aorta? I'm trying to go through 10-second delay. Do 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 boom boom. Something like that, right? Now it's with Ryan Seacrest. I haven't watched it. That's big shoes to fill. My nose is itching.
Okay, I'm gonna guess the indica, the sativa, and the hybrid. What was the question?
You're so wrong, but that is really interesting. Your answers. I'm like, we're not naming marijuana. No, the layers of the aorta. Indica, sativa, and what was the last one you said?
Hybrid. Velda
You're
says,
funny. It took me a
Initia,
second.
media, and adventitia. Molly says intima, media, adventitia.
Very good. I'll give both of them a ding, ding, ding. That is right. The intima is the innermost layer. The media is the middle, and the adventitia is the outer or the strongest. Yep. All this information is in the aortic dissection, the patient guide, pages 13 through 23, if you wanted more information. So aortic dissection, tear in the innermost layers or layer of the aorta causes blood to rush through and accumulate between the innermost layer and the middle layer. Dissection actually refers to a visual splitting of the aorta, which creates a true lumen and a false lumen. Weird names, I know. Just think of channel. So the true lumen or channel is where you want the blood flow to go. Hence, it's called true. That's where it's going to infuse all your organs. The false lumen or channel is a secondary unnatural entry that blood should not be going into. Okay, that's really not typically going to lead to some places, although I do believe that some people have organs that are fed by their false lumen. A lot of times that false lumen will clot, which doctors consider to be a good thing, unless you have an organ being fed from the not natural area. It might not be a good thing. So here's your blood flowing through the aorta. Boom! We've got a little tear right there. Okay, this is not great. Here's another side view. Blood. And then there's a tear. Okay, and there's another tear to get back in to the aorta. So there's your dissection. Where you have your 2 channels, unless you're somebody who dissects and it just goes all the way down, right? Here's another example of tear in the aortic wall. Normal aorta, all three layers. Boom, boom, boom. Again, like we talked about, intima, media, and adventitia. So there's two main types of aortic dissection groups depending on where your dissection occurs. In a type A, much more dangerous, occurring in the upward or ascending part of the aorta. Sometimes they extend downwards into the abdomen. So A, I've heard many doctors say, is anything that starts in the ascending. It doesn't care where it ends. They don't care. Some people will call that an A, and a residual B means it went past the ascending, over the arch, down into wherever. But again, a lot of doctors say if it starts in the ascending, it's a type A. It's not an issue about where it ends. And the reason it's so much more dangerous is because that's where the highest degree of blood flow. It's coming right out from the heart. It's right there. You got all that pumping. And that's where I believe your aorta is probably going to be the widest. And then it goes down to a little bit smaller, just a little bit smaller in diameter as you get towards the abdomen. And almost always, it will require surgical intervention to replace the torn aorta, usually with a Dacron graft, and restore the blood flow to the rest of the body. An interesting story about these grafts. One of the places I got to go when I was in Scotland was the Terumo plant. Now, Terumo is one of a few medical device companies that manufacture the grafts that can go into our bodies. And they have 3 plants. The largest is in Scotland. They have another one in Sunrise, Florida, and another one in Japan. And if I have the story right, because I was really hungry, it's like I didn't pay 100% attention, being honest. The doctor that started this was the doctor, I believe, that discovered tetanus and developed the vaccine for tetanus. They also at Terumo created and developed a special injector, special needle for pediatric diabetes patients so that they won't feel it. It bypasses nerve endings in their skin so that they won't feel their insulin injections. Isn't that amazing? I do remember hearing that. So we went through this plant, and all I can say is picture the chocolate factory, Willy Wonka and the chocolate factory, because all of their employees that we could see behind glass doors look like big, gigantic Oompa Loompas in blue, disposable, like surgical gowns and masks. Only the people that had facial hair had masks. They had gown-like thingies over their shoes, which was standardized shoes. I think everybody had the same shoe. So we went to one room where they actually made the material. So big spools of whatever the thread is that they use where they create. Huge machines, big bobbins. I remember bobbins when I took my class in school, learning how to sew, learning how to cook, and learning how to do woodwork and metal. And then the bobbins were these little things, right? These are massive. And all the threading and the weaving and everything. And then this fabric comes out and it's cut and it is washed and it is baked in an oven. And then it is looked at for any kind of defective issues. Goes through so many tests, and anything that might look potentially sketchy goes back to the person who was looking at it. And we're watching all this take place, and constantly someone's in there cleaning with wipes and rolling this sticky pad roller on the floor to take any kind of particles and lint, sucking. I mean, always somebody was cleaning. And once that's done, those products are sent down to the sewing room. And everybody that sews starts off in general sewing. And then over the years, with more and more experience, they can get promoted to the special order, more personalized grafts, that might involve branches and, all these things. And they get promoted to that because, with any, there's no room for error. Period. But you need special sewing techniques. And these people sew by hand. And they sit there all casual, leaning back with their magnifier mirror, and they're just, it could take me an hour to sew a damn button. But they sew this, and it's just amazing. And then they waved at all of us, and then somebody's in there with this, look like a microphone with a big metal tube, but he's checking levels of like ions and things in the air. And if it gets to be too high that there's particles of something in the air, then they have to clean the whole room. Everybody has to go out into a holding area and they clean the whole thing down, everything, and then they can go back in. It is such a process to pass anything, paperwork, whatever, into this room. There's a separate middle room where everybody undresses and they pass it and then they get redressed and they go back in. It was incredible to see. There was a woman with us she knew the device number, which then meant they could trace it back to the woman who sewed her. Could have been a woman, could have been a man, but this case it was a woman who sewed her graft, who sewed it by hand. And they got a chance to meet. She heard we were coming and she came in just to meet this survivor, and it was like not a dry eye in the house. And I think that the reason they, like Edwards Life Sciences, have these patient days is because, whenever you have a job, it becomes like you have your blinders on, you just go to work. But when they have patient days, these people that help create products that keep us alive get a chance to meet people who are standing with it in their chest. It's just mind blowing. And so immediately I was like, called my doctor. I'm like, who did my graft? And what's the serial number? I'm still working on that because he didn't put it in his notes on my medical records. But yeah, if you have an Edwards valve, you need to go onto their website and apply for Patient Experience Day. Just keep your eye out for that information. If you know you have a Terumo graft and you know the registration number, I would try to reach out to them and see if you could go to their plant in Florida, unless it was made in Scotland, and see if there's a chance that you could meet the person who did it. It is so life-changing for both parties. So I'm just going to throw that out there. So that's when we're talking about emergency surgery to replace the area that has the tear, okay, and restore the blood flow to the rest of the body. So depending on the extent of the dissection, your surgeon may perform a hemiarch repair, which I just learned today is what I had. And that's when they replace the part of the ascending aorta only. Or you can have a total arch repair with or without an elephant trunk to help repair more extensive dissections. So here's a type A ascending aortic dissection, and here's the repair, hemiarch. It did not include the arch. This is what I had. It just included the ascending, go up the aorta coming out from the heart. We're going up and ascending, and it's just replacing this, but not including the arch, which would be a total arch. And then if you go down, I believe that's the elephant trunk, because it kind of looks like an elephant trunk, right? So here is type A repair, arch, and frozen elephant trunk. So this is very interesting. And I think it was Dr. Caterina, one of them showed us this product. It was Mascaro, where they do a graft and then it's a stent that goes in to the descending. And this, of course, includes a portion of branches. I'm sure it can, include more. Type B dissections include a tear in the lower or descending aorta. So the ascending part is not affected. So if you had your dissection anywhere from the arch down, that is B, or as Dr. Udelman says, descending. But it's descending because you're not ascending. You're not going upward. You're now at the level area of the arch and coming down. That would be type B. But if it involves ascending, it's type A. Just goes back to that, okay? Type B dissections can usually be managed medically at the initial diagnosis point as long as the blood flow to your abdominal organs and your limbs is unaffected. Sometimes your surgeon may place an endovascular graft into your descending aorta to help reinforce your aorta, expand that true lumen, which is the right channel that we want the blood to flow down, and cut off that blood supply to the false lumen. Sometimes. This would be made, again, by making a small surgical cut in your groin and will often not require a full surgical cut down. So here's your initial tear, type B. This is true lumen, all that nice blood flow. Coming here. This is the false lumen because the tear was right here. It goes into the false channel. It's not going anywhere. It's leading to nowhere. So the true area where blood can flow to all your organs is diminished. And they put a stent in here so that it makes it bigger. See, this whole diameter looks much bigger than this diameter because it is, because you have a false channel. So they opened up this channel area with the stent on the inside. And this would be the exit, the distal tear, where everything came back in and is in the true lumen again, leading out to, I think this might be renal arteries. All right, so diagnosis of a dissection requires some sort of imaging. You have to have imaging, and it's typically a CAT scan that is considered the gold standard of aortic dissections, as they allow clinicians to visualize the entire aorta, One false swoop, which is very useful because it'll help them distinguish, is this a type A or is this a type B? Additionally, your doctor will probably include contrast in this. Sometimes I would think that most times, if you're in the ER, they're going to require contrast. And even if you are allergic, you will still have to have a pre-medication concoction of Benadryl and Salumedrol, which is prednisone, but it's Salumedrol when it's in the IV. That might take more time before that hits, like 45 minutes to an hour before you can have your CAT scan. But the contrast actually helps them distinguish between the true lumen and the false lumen and check for organ perfusion, which means that the organs are receiving good blood flow. Malperfusion means they're not. So here's image of a CT scan. That's a really good image of a dissection. It's just cut right through. Cut right through. Okay. Conversely, an echo or an echocardiography might actually help show aortic dissections in unstable patients who cannot withstand going into a CT machine. Now, that can be body size, weight, claustrophobia, many other issues, who knows. An MRI takes too long to do the entire aorta. You're looking at 40, 45 minutes, but an echo will get the most key critical area, which is the ascending, again, because we talked about the amount of blood flow coming out. So if you cannot do that CT, then they're going to order a quick echo. And certain parts of the aorta, the distal ascending and arch, they can be hard to visualize on an echo, getting into the arch area and then coming down the thoracic, but they can see the ascending. And I guess I don't know. I'm not a doctor. Is this the dissection? Your guess is as good as mine. Don't know. But this is what the echo looks like. All right. At Aortic Coat, we strive to be aware of the early symptoms of an aortic dissection. And these may be common presenting signs to facilitate early medical intervention. Remember, there's no one size fits all. There's many people that felt nothing, some that just felt off, some that felt one symptom, and some that feel some of the most intense symptoms. But traditionally, majority of people might feel a shooting pain on their upper chest or upper back, spreading to the neck or down the neck. Okay, that's one. Sudden stomach pain could be another. Fainting, loss of consciousness, shortness of breath, sudden vision problems, sudden difficulty speaking, weakness, loss of movement or paralysis on one side of the body, weak pulsations in one leg or one arm compared with the other, pain in the lower extremities, blood pressure that's off by over 20 points in either limb. In addition, it's very important to familiarize yourself with some of the more common risk factors for aortic dissection, and that would be typically male. They will have a dissection, and it's usually abdominal, which high degree of people that have that. Older age, high blood pressure. Again, you don't need all of these. You don't need all of these. Just need a nice, good little combination. Atherosclerosis or hardening of the arteries, bicuspid aortic valve, Turner syndrome, which is a chromosomal disorder only found in women. Connective tissue disorders such as Marfan, Ehlers-Danlos, Loeys-Dietz, ACTA2. Having a pregnancy, especially if individuals in pregnancy have preeclampsia, which would lead you to having a very, very, very high blood pressure. You will know if you have preeclampsia. I mean, the best way to cure preeclampsia is to deliver. So if you're further along in your pregnancy, your doctor will probably have that conversation with you. But I'm talking blood pressure of like 215 over 120. Like, it's high. It is painfully high and usually goes right away the minute you deliver. Intense weightlifting, that can do it too. Smoking, and of course, having a family medical history of sudden death, high blood pressure, heart disease, stroke, diabetes, and of course, any type of aneurysm. So that's all right. That's our post from Adam. A lot of information about dissections. Again, you can get detailed information from Aortic Dissection, the patient guide. And our second guide's coming out. So that was on Aortic Dissection Awareness Day.
That's excellent. That is excellent.
Yep.
Hey.
Good posts, good information.
So Molly up here, she put in the chat, I heart my Adventitia. And I feel like we need a t-shirt for that.
It should be, what is it?
But I'm thinking more along the lines of I, the aortic cope icon, my Adventitia. We can figure that out. But I like this. I like this.
I like I for intima, heart, M, media, put a little y, A, adventitia. Love your aorta. Ah,
Right?
think aorta.
Molly's
Oh,
awesome.
I'm making it happen.
So Velda here says interesting inventions. She loves chocolate and she'd love to go to that plant. And then she says, Josh, my interview is on CBC app now. I got the message from Natalie. So we have a
Very
link.
good.
We have
All
a
right.
link.
We have a link. Very
Okay.
good. Okay.
And I said, well, can you reach out and see about our ability to post it? Oh, they can post a link to the interview, but it is against copyright rules to add it to their YouTube channel.
Ooh.
And so I don't know about that. That makes me so both mad, angry, and so forth.
You know what? Videotape it from your phone and upload it.
Well, it's not that we can't use it. I mean, we can use it. It's the there are these things in YouTube. It's a whole
Yeah.
genre, and it's a reaction video.
Okay.
And what you're doing is you're creating new art because you're not. It's like a direct copy would be like, this is this article, and then because you said that, and then you stop talking, and then the article plays out, and you do not
Yeah.
interrupt the article at all, you have basically plagiarized said article.
Even if you say this is the article from blah 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 to go
Yep.
check out
Yep.
here.
Okay. So, however, the method in which that you do a reaction video is like there's 15 to 20 seconds of the video playing, and then you pause the video and you interject. Okay.
Oh,
Right.
okay.
And then you go back to the video and then you pause the video on this little routine over and over again and you interject. And so basically you're interspersing your portion of the contribution of the new art inside of the thing that you're quote unquote plagiarizing, but at the end
Right.
at the end, because it's not one continuous just a copy paste of somebody else's work, that's allegedly how you get through YouTube stuff. Right? And then secondly,
Interesting.
is the question of copyright laws and whether or not I care about Canadian copyright laws. So, that
I
too.
might care. I could care. Care for me.
I'll see what I can do.
All right. Well, while you're seeing what you can do, we had an exciting announcement. This is really exciting. In case you missed the first announcement, which we talked about last week, we're so excited to announce the following joint statement from Think Aorta. This will be global mothership, right? And the Marfan Foundation regarding the global Think Aorta campaign and the organization Think Aorta US. The Marfan Foundation says, and I quote, "Our mission is to save and improve lives while building community. By amplifying the message to think aorta when symptoms present, we will undoubtedly save more lives together. We are proud to help Think Aorta and Think Aorta US educate more people about the signs, starting with Aortic Dissection Awareness Week 2024 and moving forward." And Think Aorta, in turn, said the Global Think Aorta campaign welcomes the Marfan Foundation as they announce their alignment with our life-saving campaign in aortic dissection and commit to amplifying the Think Aorta message around the world for all patients at risk. Patients with Marfan, Loeys-Dietz, or vascular Ehlers-Danlos syndrome have a 250 times greater risk of experiencing a life-threatening aortic dissection in the general population. There's a whole announcement that you can click on the link, but Aortic Hope fully supports both the Marfan Foundation and the life-saving Think Aorta campaign. This outward show of support marks a pivotal step in the Think Aorta, Think Family initiative, aiming to educate the aorta community about the critical importance of family history and understanding and managing aortic diseases. Collectively, we will amplify the key messages of the Think Aorta campaign, which stresses the urgency of recognizing the symptoms of aortic disease, a potentially fatal condition if misdiagnosed or left untreated, as well as identifying those at risk for aortic disease. Join us in this critical mission to advocate, communicate, educate, and save lives. Think aorta, think family, think community. Ba-ba-da-da. It's exciting. So
Now
even though
hear this.
well, see on Facebook, all these things move. So you're missing all the fun of the graphic. It's still a cool graphic. But, while the connective tissue disorder community has 250 times more likely to have a dissection, for every one of them, there's 5 of us that don't know what our genetic relationship to aortic disease is today. I say today because in 10, 15 years, you may know something. You can have multiple family members and you all test negative. So there's for every 1 that knows, there's 5 that don't. So we are a larger community, and collectively we'll still be impressing upon the physicians the importance of thinking aorta with all persons, not just those that walk in with the golden ticket saying I have a connective tissue disorder. You need to think it with the people that don't, that talk about family medical history or anything such of that. You need to talk about it. So it's exciting. All right. That's the exciting announcement.
So Christina says, Molly
Mm-hmm.
means that outside layer is keeping or kept us alive. Therefore, I love my adventitia.
Yes. Yep.
And then Molly says, because my adventitia is keeping it all together. And then I say, I'm envisioning a children's book from Steve's Annie the Aorta. Or Aorta Annie. I don't remember how we said it.
There's Miss Aorta who married Mr. Hart, and there was a children's pamphlet that went around, and then it just wasn't effective
It
because
never
then it
is.
started talking. No, there's no way to really talk about a CT scan without getting into kind of medical terms that kids don't really care about. Hmm. It's hard. You have to really think about your age group. If you're talking to preteens, they're going to get more. You can get into a little bit more detail. And there's been Lady Aorta. She wears a dress. It looks like a stent. There's been some fun things floated around. So yeah,
Yeah,
like we.
Steve charmingly named his aorta Annie because he would tap his
Okay,
chest and say, Annie, are you okay? Are you okay? Are you okay,
that's
Annie? I
hysterical.
know. And when he shared that with us, we couldn't talk for minutes. We were all laughing hysterically. It was
That's
amazing. It
so
was
funny.
amazing.
I know a lot of people in the colostomy community. They name their colostomies. I didn't know it was a thing, and they all name them variety of names. They're stomas, and that's how they refer to them. I'm like, but you didn't refer to other body parts before you got it. But yeah, so I had to come up with a name, and I like my name. Mine is named Bob because
Yay.
Bob stands for butt on belly. It was a great way for us to refer to this in the family in the early years. Like, is Bob okay? You going to be okay eating this? Like, is Bob going to have an issue? And this way I didn't have to talk about it. And then the longer I went not talking about it openly, the worse the name Bob became. I was like, don't talk about Bob. Only I can mention Bob. So I just realized, you know what? Forget Bob. I'm just talking about it. Like, we're done. We're done here with the Bob thing. Yeah.
I like
So,
that. And it
yeah.
reminds me of the time I got to visit with John Brenny. Now, I'm going to share a little bit about John. John is not a Tom Cruise fan, period. Just doesn't like it. But in the movie Maverick,
Yeah.
the latest Top Gun Maverick, there's a
Mm-hmm.
scene where a guy is sitting in a chair and his flight name is Bob.
Okay.
And they go, well, okay, Bob, what does that stand for? And he goes, Bob.
Just Bob. That's funny.
But butts on
All right.
belly. Butts on belly beats
What's on
Bob.
belly? Yeah. Uh, Also on the 19th was our 6th annual Community Hope Campaign. We've been doing What Does Hope Look Like? I can't believe this is our 6th year. And I can't believe how we started to where we are now. Like when we first started, we had everybody holding a sign with an arrow pointing up that said, this is what hope looks like. Take a picture. And it was cute and it was effective. And now we have people submit photos, any kind of photo. And I think this is our largest batch of people that submitted. This video is very long, but I know it's fun. People like to wait to see their picture of themselves. So, if we missed anybody, we apologize, but there's so many submissions. And we're often reminded of all of the people who had aortic disease that are no longer here. And I think it's very important to know their stories. There's always something to learn out of that story, but I don't have anything in common with people that are not here. I have, in my opinion, much more in common with all of you that are fighting this every single day, and the people that work so hard in the community, volunteering their time to help others live their very best life. And that's why we wanted people to see what hope looks like, because it looks very differently, just like this disease. There is no face of aortic disease. There is nobody that looks like they have aortic disease. Sure, there was the stereotypical look of a Marfan patient, which is so dangerous to say that, because there are plenty of Marfan patients that are more stout or short and don't have lanky arms. Just like people with Crohn's disease, people envision them to be extremely skinny, almost emaciated. And there's so many that are not, that are way on the opposite end of the spectrum. And that becomes problematic, and I think very scary territory when you stereotypically, especially when physicians will say to us, well, you don't look like you have Marfan's. Well, that's so silly, right? So we're not focusing on that. We wanted to focus on what hope looked like. And I will click this just so you can get an idea on how it looks. I don't have the music playing, but the music is great. And it basically just runs through all of family photos, and it's just lovely. It's just wonderful. So if you submitted a photo, I highly recommend you click on this. There's John. Click on this. I love seeing everybody. It's Nicole. I love now that I can recognize. I can't believe I can actually remember names. I don't remember that one. So cute. So I do highly recommend you check this out and check out all of your the people you have a lot in common with. Check out and see what hope looks like. 6th annual Hope campaign video. So thank you, Josh, for helping us put that together. All right.
Yay,
this
me.
Next post was the focus of the conversation that I had with Ben. Not the conversation, the presentation that we did in Scotland. So we were asked to talk about physician-patient relationship. And before I show you this, let's talk about this, okay? Ben got up there and he started this presentation by saying, this is so silly. This is not open for discussion. You come to me, I tell you what to do, you say yes, you go home. You have a problem, you call me back, and we start it all over again. And people, of course, cracked up. And when it was my turn, I was like, so thank you so much for your opinion. Let me tell you how it really is. Come on, everybody, see how much you agree with me. Traditionally, doctors with their white coats, teachers with a stick of chalk, police in a uniform, we just put them up very high. This is how we were brought up. There was an element of respect that's given for their education, for their position, and that all is fine. But there was definitely this line in when you go to a physician, you don't feel well, and they told you what to do about it. We didn't always have Dr. Google. We just did what we were told. We didn't ask questions. We didn't think to do second opinions. We just did it. Even if we didn't like it, we kept our thoughts and feelings to ourselves. So now we take the medicine or we have the treatment plan and we're uncomfortable. We're not calling to irritate the physician, to say we have to leave a message again. Then they think we're the complaining patient. You cannot piss off the gatekeeper, right? Plus, we don't want our doctor to think we are challenging their thought process. We don't want a physician to think we're being disrespectful, that we're being a hypochondriac, or that we're whining. So we just keep everything to ourselves, and we hope we feel better. And then either we feel worse or we get better and we have another problem again, and the cycle repeats itself. And that has traditionally what occurs in all facets of medicine. That is not a recipe for success. That is not sustainable. And in the year of 2024, with buzzwords like shared health decision making, it really came to me, how did I make this relationship work with Ben? And I realized that because of our relationship, Dr. Udelman and myself, so many things changed in my life, because this is how I saw physicians. They tell me what to do and I do it. Well, I'm not going to question anybody. But when Dr. Udelman reached out to me for something unrelated to Think Aorta, it was something about, do we have enough volunteers that can answer questions from caregivers when he's doing surgery or afterwards? And I said, yes. I didn't know if we did, but I just said, yes, I'm going to help anybody. I was so scared. For those of you that have seen Dr. Udelman, what's to be scared of? He's so engaging and charismatic and empathetic and patient and smart. But I was nervous. I was very nervous because, he's a doctor and I was nervous. But then I found out he's like a year older. I mean, he's like a month older than me. So, and he's still older than me. I'll take 30 days. I don't care. But we were more like peers. And in order for me to be able to help all of you, I had to be able to be comfortable with him. I had to be open and honest, not only sharing my stories, but being able to share the questions and the problems from the community. I had to advocate for everyone. I have to do that through communication and education. And then he needs to do the same with me so that we can better enhance the experience of the community. But ultimately, I started doing this that I'm going to show you right now in my own healthcare journey. And it came down to having people learn how to ace their healthcare journey for a two-way street to success. And for all of you, what I think you need to think about in order to have the most worthwhile experience with your physicians is, number one, to advocate. And to advocate means you need to speak up and share your wants and your needs as a patient, or as a physician, you have to do the same thing for your patient. So let's just talk about patient to physician. You have to be able to find a way to speak up and share how you're feeling. For a lot of people, that means minimal. Answer questions when asked, and that's going to be effective for you. That's your personality type. That's fine, as long as you communicate that to your physician. But the other thing you need to do when it comes to advocate, if you are a physician, is you need to speak up for your specialty and the treatment of others with the same disease element. We'll get back in that a little bit. But the way you advocate is by communicating. And that means sharing information about how you're feeling mentally and physically with your physician, and you have to be honest. And again, there are some of you that don't want to share, but as long as your physician knows that and it works out between the two of you, that's fine. And you can share via text, email, phone call, in person, whatever works best for you. But you really do need to be honest how you're feeling. And that has to include your mental health as well. And as a physician, you have to learn how to share information with your patients. You have to learn how to best communicate. One size does not fit all with everybody here. Some people are visual, which is why we leave the sample body in the back of the disease, the patient guide, the aortic dissection and disease patient guide, so that they can draw diagrams, so you can take notes. Because what you're doing then by your way of communicating is you're educating. You're educating yourself about the disease. You need to educate your physicians about your disease. How many of us have had to go in and explain to another physician what's happened to us? Some reason they understand what an aortic aneurysm is, but when you say you've had a dissection, they freak out like they can't believe you're alive, and you have to educate them. You also have to encourage your physicians to educate their colleagues, because we know the most ideal situation would be your surgeon talks to your cardiologist, who speaks to your primary care, who might have to talk to your gastroenterologist, let's say, if you need your gallbladder removed and they want to talk about any issues you might be having from a cardiovascular standpoint. So physicians also have to advocate for you by communicating and educating information about you to other physicians. And that is the way that you're going to have a two-way street to success. This is not a power struggle. It's about power balance. It actually isn't about power, but it's about balance between both parties. And then what we realized visually is when we start doing this between ourselves and our physicians, as patient leaders with an organization, you start feeling more comfortable in how you present information to the community. And I hope that some of you have felt comfortable taking this method to your own physicians and learning how to ace your own healthcare journey, because that, again, really is the two-way street for success. So that was our presentation. I was very jazzed about it. I think we really nailed it, and everybody really liked it because our presentation was so colorful. It wasn't very sterile, and we were animated Americans using our hands and arms, and we were laughing with each other, and and all that good stuff. So hopefully you like this. I've got some feedback recently and people seem to really like it. Hopefully it resonates with you. But most importantly, I hope you think about this and utilize it in a way that helps you ace your healthcare journey. That's that.
That's so exciting.
So exciting.
Right?
I can't wait for you guys to see the presentation.
Me
I hope
too.
it, from an auditory perspective, everybody can understand.
Well,
Good.
We can always just re-record it. So Tony
Yeah.
Montana jumped in to say hi.
Hey,
Hey, Tony Montana.
right? And he is 1 year anniversary is this week.
Happy aortiversary.
I
What are you going to do
know.
to celebrate?
Good question. He
A lot of people
says,
get stuck on that.
uh-huh. He says, it's taken 1 year for me to get connected to a cardiologist. And if it wasn't for Karen and you, I would have no idea about this journey.
I'm happy.
Right?
It's a village. It's a village though. It's not just me. It's a village. It takes everybody. But appreciate the kind words. You need to do something special. And I'll tell you, one of the things that's most special is when you're able to go back to the emergency room physicians that helped you. If you can get in touch with transport and find out if there was an EMT house involved. You just need to get back and tell them what you're doing. Every year I send a message to the ER doctor who ordered the CT scan without waiting. And I tell him everything I'm doing in my life, everything I've accomplished from the prior year. And he waits patiently for January 29th because he knows that long-winded email's coming. So it's almost like he's been there while I've helped my child learn how to drive, graduate high school, get into college, graduate college. Now he has a big boy job. Like he's been part of everything we've done with Aortic Hope in the community. And he loves it. And I became friends with the transport nurse who let me use her cell phone when I was in the ambulance on my way to the big hospital, calling everybody, like wrapping up my life. We stayed friends, and very special nurse on the floor every year. I used to go back before COVID and would drop off bagels or cookies or little tchotchkes from Aortic Hope to the SICU, to the ICU ward. And it was therapeutic for me. They would always let me walk one lap around the floor, and I looked into room number 5 where I was. And I remember when I walk around, I just think, God, these people are really sick. And then it's like you realize, shit, I was one of these people. But then I get to leave. So I usually scurry out of there with a little bit more rapid pace than when I walked in. Not because like I'm scared, but because it's time for me to go. Like I've had my time and I want to leave, and I leave when I want. So just some ideas. And I think you should celebrate with family and friends if you want. It's a special day. It's a special day. Good for you. Congratulations. All right. Friday fundraiser. Look at that slick looking magnet. That's a great looking magnet. It's actually oval. It's not square. Here it is. Boop, 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 boop. Put it on your car. There's places on the cars that stick. Fridge. If you're at work, file cabinet, something like that. Great to give doctors because they have metal file cabinets. There are still paper at doctor's offices. It's a great gift. And it can be yours today with the $10 donation. You just need to use the form but down here or go to Hope Shop, and it's on our main form there. $10. You can get one. Start spreading some awareness. All right, that was Friday. That leads us into Saturday. And I did not watch this yet because I was still in Scotland and I only came home late. I mean, yesterday.
That's
and
okay. Allow me.
Sick. Please tell us about Martha Morris from Canada.
Martha did a beautiful job.
Good.
She told us a wonderful story, and like her, she's a slow talker, so her pregnant pauses were building up quite. Like I'm just like, am I lagging out? No, no, no. Martha's getting there, but it was a beautiful story. Her husband found her on the floor without a pulse when they called 911. And she still didn't have a pulse when the emergency people showed up. And she was like, but I think I'm fine. And they were like, no, ma'am. It's an incredible story. And it's, we took some conversation from the chat as well. There was, we had so many well-wishers from Canada, and she's really stepping up. Her and Velda both really getting out there, really trying to help push Aortic Hope Canada. But one of the nicest things to come out of this is, due to some of the strokes that she had during her surgery, she didn't have the ability to write. But now she's in a writing group, and they like meet every morning from like 8 to 10 or something, and they don't talk. They're just on a Zoom meeting, typing away at their books, okay,
Very nice.
and then doing a little sharing. And I thought that was so wonderful.
Yeah.
And again, addressing some of the concerns, about any lasting issues from her surgery. She had She had some trouble with her right arm, but
Mm.
she has since gone back to play in a concert band so she can play the flute again. I know, right? This is our
Oh, I did
Martha.
not know. I
I
never
know.
knew. Wow. That's amazing. I had no
Yeah,
idea. Well,
she's
we need her
so
to
great.
play. Well, I want her to play for us and do a little mini concert.
Well, you're gonna have to jump on that one.
I
And I
am going
know
to.
I know somebody that can help you. Both Molly and Velda would also help with the peer pressure.
Yeah. Yeah. I'd love it. That would be wonderful. That's so great. And there's so many wonderful things happening in Canada. And I'm so glad that she and Velda and Rebecca Wiseman is another volunteer as well. She helps with managing the page, the Aortic Hope Canadian Private Forum. There's a lot that's happening right now. So GATA, the Genetic Aortic Disease Association, is the primary sponsor and endorser of Think Aorta. And there's a lot of changes that are getting ready to happen there. And as they start to uh, talk to more and more physicians, obviously closer to the border where a lot of the patients would be transferred to, those patients are going to be referred to Aortic Hope. So we're going to have to look into finding physicians that might want to go live, looking to have somebody who might want to interview them. You and just start showing some of the love and initiatives that we have. We'll start bringing some of those to Canada as well. So that was also things that came out of this meeting this week. I did have a many times to sit with Lindsay Roosh from GATA, and we just started nailing out, and hammering out some things and thoughts. And I just love that they're fully supporting Aortic Hope and want to refer patients and caregivers to us for that support. They have very specific support group meetings. Don't get me wrong. They do offer support group meetings and webinars. Their support group meetings are topic based, which is interesting. Ours are general, and on occasion a physician shows up, which then it can become topic based. But theirs are very much come to this support group meeting if you have aortic valve disease. Okay, so then you would go to that with obviously a connective tissue disorder. So I love that they do something that's topic based, but they really love that ours are just open in general. So I think that's great. And I love that we have both of them. And I thank you, Martha, for sharing your story. And I'm going to get you to play the flute. So there. Okay, we're almost done. I
Hold on.
promise. I know
Fact
you.
check.
What?
Fact check. Christina
Okay.
says Martha regained consciousness when her husband rolled her off the couch to the floor. Boom. And then her pulse came back before the CPR started.
Wow. It's all so
Thank you,
scary.
Christina. I love her.
Yeah. Very good information. Scary, but good information. All right. I experienced this spoon theory while I was away. You guys know me. You know I push myself. I do a lot. And you think it's easy, but there are days when I crash like I have narcolepsy, and I am not even over exaggerating. And it happened more than once on this trip, and it was not jet lag. I was totally fine. First night, slept, no issue. I was stayed up. It was almost 20, it was past 24 hours, but that's just with the time zone difference. But I really felt great. The first full day I was running on empty. But the first full day, we left at 5 p.m. Eastern, got there at like 8 a.m. their time, which is 3 a.m. my time. And we met up with Ann Cotton from Aortic Dissection Awareness UK and Ireland. And we had a great breakfast and we kind of started going exploring. Okay. By noon, it's like Forrest Gump. He's running forever and then he just stops and he just says, I think I'm going to go home now. Well, I stopped literally in the middle of a street and everybody looked at me and I was just like, I have to go to sleep right now. And I just called an Uber and that was it. I just got into, I didn't even care if the hotel was around the corner. I had to be in the car because I would have gone on this wall and just fallen asleep in the middle of the public. It was so bad. So I slept for about 2-3 hours, got up, we went and we made pocketbooks, had dinner, and then I went to sleep, no issue. And the next day, we had this 8-hour tour, and I slept a little bit in the van. But on Thursday, on the day when they spoke, when I was finished, there were still 3 speakers. I had to leave and go across the street into my hotel room, where I had Dr. Udelman's daughter in my room studying and doing homework, and I was fully clothed with shoes on in my bed, eye mask, earplugs, fan on, out cold. And I did that again on Saturday when we did a tour. I hit hard. I just was done. I was depleted. And let's take a look at what depleted looks like and could look like for you. So the spoon theory was created by a woman who actually had lupus. And people, her friends, you don't see lupus, you don't see aortic disease. And people would ask her, how do you have energy to do this? And why are you telling me that you can't do this now? And blah, blah, blah. And she just found it so challenging to explain what it's like living with a chronic illness and how it changes. So she said, she created the spoon theory, which is a metaphor used to explain the limited energy available to individuals with a chronic illness or a disability. And how it works is your spoons represent units of energy. I'm trying to see how much this was here. Right. Okay. So people with disabilities start each day with a limited number of spoons. You wake up and you have all these spoons in front of you. Just imagine that. But each task, like getting dressed, costs a spoon. So you wake up, go brush your teeth, that's a spoon. Got to get dressed, that's a spoon. Got to make and eat breakfast, that's a spoon. So I don't know how many, you've already been through 3 spoons, you haven't even left the house yet. And everything that you do is a spoon. But most people with chronic illnesses or disabilities use up all their spoons before dinner. Because to them, to us, even having to sit at a desk job and just be present and be able to converse with lots of people and be able to think through that could cost you 4 spoons. You don't have any energy left by the time you get home at the end of the day. You are spent. But some days you might have a couple spoons left. Whereas for people that do not have illnesses or invisible disabilities, these things all have a dollar value or spoon value across the board for many people. So 1 spoon here, 1 spoon there, 2 spoons, 1 spoon, but they have plenty of spoons by the time they get home so that they have the energy to accomplish what they want. Go to the gym, hang out with friends, go to a movie, go shopping, whatever. Not us, okay? The significance of this is it really helps through a visual. It helps other people understand the daily challenges of living with a disability where simple tasks can really quickly drain the energy from us, and choices have to really be made about how to use the limited amount of spoons that you have. And it emphasizes the need and understanding to have understanding, actually, and have compassion towards those that are managing invisible illnesses. So if you have difficulty explaining to others what it's like living with aortic disease, valve issues, etc., the fact that it's not visible, this is a great tool. Just grab a handful of spoons, give you some, give them some, and have your chart. For them, this is equal spoon. For you, this is equal 3 spoons. And that's really it right there. The value of the energy that you're expending is more spoons for you than it is for them. It's also very important, I think, to share this with caregivers. Comments have been made to me from my own husband, like, how do you have the energy to go to Scotland, but you don't have the energy to do your laundry right now and take it upstairs and actually put it away within this next 7 days, or dust? And I'm like, it's different energy to go out to a movie than it is to dust. He's totally amazing about stuff like this. I'm just giving it as an example. But when you share this with your caregiver, it might actually help them understand how you might be feeling, because they don't know, they don't have this, right? They don't really know what it's like. So spoon theory really is an amazing way to help others understand what you're feeling when they can't see what's wrong with you. So try it. Love to hear your thoughts on it and how it might have worked for you. All right. Let's go over the events real quick, because we did reschedule tonight's live event that was supposed to happen at 7 with Dr. Tyler Wallen. It has now been moved to Tuesday, October 1st, September 7th. Why? Because I'm out of spoons. I'm sick and I'm out of spoons. And that's just what it is. This trip really threw the spoon theory in my face. And everybody around me, Gareth and other people and Terry, they're like, Karen, why are you apologizing because you have to be done and you want to go to your room? Like, we all have to put our health first. But you guys that know me know that it's so hard for me to say no. It's so hard for me to listen to my body. But these were situations where my body was like, I'm not giving you an option. You have to stop. You have to stop now. And I've never really experienced that before. And it was weird. And I was psychologically just so torn. But the voice was so loud in my head that I had to stop, that I did. I did listen. And I took it very easy for the remaining 3 days and just really did not overextend myself, didn't commit to things. And I still got sick, so it didn't matter. Ugh. I'm so glad we haven't erased any of this, because I really want to capture this to know for next year what we were able to accomplish this year. All right, guess what? Let's see where we're at. Almost forgot. All right, we have a live Q&A tomorrow, so if you hit the bell, you'll be notified. Again, this is talking about Medicare with Rosie Paulson. She is the wife of community member and community liaison volunteer with Aortic Hope, Scott Paulson, who actually plays Santa Claus in the wintertime. And we have been put on the nice list, so we will be visited by Santa. I'm not sure how that's going to happen. I have to talk to his elves, but that will be happening. We have a support group meeting on Wednesday the 25th. That is the last open general support group meeting of this month. And I'm sure there'll be some type of mini celebratory event over Aortic Disease Awareness Month, followed with our hangout with Rob and Mindy on the 26th. Then we have another live event. Well, on the 26th. Oh my God, that's all this week. Okay. Lawrence Hope Medical ID Jewelry, Tara Cohen, going to break out hopefully some of the fall products that are coming out. We're going to do some type of trivia. She just always wins. I just don't want to play with her anymore because I don't ever win. But we're going to give away products and gift cards, and we're so super excited about that. So you really want to hit that bell, get notified, join us, okay? Qigong every Sunday, 12:30, amazing, wonderful event. And then our last live event of Aortic Disease Awareness Month is also an important one, and that is with the law firm Doherty, Chella and Keene, Doherty, Chella, Keene, and Associates. We work with Chris Doherty, Barbara Mountain. They're going to teach us all about the disability process because it can be very arduous. It is a process. It has a high likelihood of going a certain way for most people, but that's not a rule necessarily. But it's important to learn. It's important to know what happens when they contact you again after you've been awarded. What's the difference between SSI and SSDI? And there is a difference. Who qualifies, blah, 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 why it's important to work with an attorney, because you don't pay for it. It comes out of your retro pay. But why is it important? And there's so many benefits, including benefits to your own mental health and physical health. So please join us for that. And that will wrap up our September Aortic Disease Awareness Month. And then we're all on vacation. No, I'm kidding. It will be a little bit easier in October and November, because then we have to gear up for December, for our 31 Days of Hope and Joy. I will tell you, we will have bingo in October. It will be a costume contest. I'm excited about that. We already have that live event with Tyler Wallen. So we're going to have, it's going to be a busy month. We're going to have our aortic artist, Diane Bishop, doing another craft with us in October. We had so much fun. I love seeing Christina's pot. I have mine sitting right here. She's going to hold my, she's not holding much when this is over her eyes, but I'm going to hot glue gun this, I think, to the hair. This one's going to hold pens and pencils and stuff. I'm got to move this over her head. It's the knots coming undone, but you see, freaky. She's kind of freaky looking. So that sits right here. I can't wait to do. I love doing crafts. I love taking my mind off of everything anyway. So that is our events. Busy, busy, busy. Yeah, that's all I got for right now. But what we need to do is pull 5 winners from everybody who participated, and you get your choice between a decal or magnet. If you've already received that and you would like something else, just put random. And I have some things I think maybe you haven't gotten, and I will not send you those 2, but I'll send you something else. Could be, what do I have here in my fun drawer? It could be a stress ball. It could be a hot cold pack. It could be a magnetizing bookmark that has a ruler attached, a keychain, pen, pad. You never know. I don't know. I'll just go break up into my little drawer here and pull out some goodies. So yeah, let's go. Let's pull some names there.
Hey, Karen.
Josh.
First off, I think everybody wins.
Okay, everybody wins.
Yeah, that'll be easier.
Okay.
Rob wants to let you know that Aortic Kitchen's back on in October.
Yes, it is. That's right. I got your email. It is. Although I was waiting to find out what the cooking class was. I think you were still working on that the last time I got that email. But if you want to share that, you can while I sing my song for the 10-second delay. Here we go. One last time. Do, 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 do. I'm going to cough. I can't do it.
What were the prizes again?
you get your choice automatically if you want a decal or a magnet, or if you want something random. Random, decal, or magnet. Random, I have no idea what you're going to get, but it's going to be fun. It'll be great. It'll be something.
Okay, so
Or
I've
you can choose
instructed
decal or
everyone.
magnet.
I've instructed everyone
Thank
in
you.
the chat. Send an email to info@aorticope.org and request a
Right.
decal, a magnet, or random.
And give me your mailing address.
Yeah,
Just
with
put
your
it
mailing
which
address,
one you want.
obviously.
Yep, and I'll get those out.
Let's see here. Can we get that British cardiologist back from LA?
The surgeon,
Mm-hmm.
Dr. Caterino.
Mm-hmm.
Can we get him back? Yeah,
Mm-hmm.
of course. I can even see if he wants to join a support group meeting. Absolutely. I had so much fun with him. Yeah, not a problem. Dr. Mascara, too. He's a heart and lung transplant guy,
Mm-hmm.
and they created that special graft that then goes into the elephant trunk. And I met the physician that was on that team with him, and the first patient that ever had that done. And she was the one that met the people at Terumo. So it was like this whole big deal. They like designed it with Terumo. It was amazing. But yeah, I'd like to have him back sometime in the first 2 quarters of the year.
Okay.
He was good. Yeah. For sure.
And then he says, I'm not sure if we know this lady, Dr. Joanna Echekwe, a leading aortic valve surgeon and the chair of cardiac surgery at Cedars-Sinai Medical Center, Los Angeles. Do we know her?
If I do not, if someone has contact information, you can send me an email.
That'd be cool.
Karen, Carin, at aorticope.org. I'm always open to getting new contact information. I love interviewing somebody, especially if it's like show and tell, and they'll show us valves. I want to learn all about the things that are happening because it could happen to me. So you know me, I like finding out about stuff that could happen to me. I love utilizing this platform to self-serve. I can't help it.
No, that's
it's available.
Great. That's great.
Mm-hmm.
Rob says that he thinks it's time for a knife skills review, which I think would be fun, right? I love watching
I think that'd be great.
Work. Yeah.
Yeah, let's restart the year over again. I like knife skills and I like hygiene. And I like wait a minute, I'm gonna get the word. No, I'm not. Prep. Meso, what is it called? He knows what I'm talking about.
Meal prep?
I can't say that. Prepping your workspace before you cook. When you have everything already diced and chopped. It begins with an M. And just words escape me. He'll write it down. But I like when we can talk about the best way to set your kitchen up. Let's talk about, sometimes people don't realize when they cut with chicken, you got to use that hot boiling water to clean it off, get all the germs. And knife skills is great. Yeah, I love that.
Right on.
Learning about the different knives, choking up on your knife.
Tony says that she's the British doctor's boss.
She's Caterino's boss. Okay.
Right?
Yeah. If you get a contact information, can email me. If you can just get me her first name, last name. If you get an email, great. I will be more than happy to reach out. I'm hoping to meet with a lot of them when I go out there in January. So I would love to include her in on that.
Right on. Rob says, mise en place.
Yes, thank you. I was going to say something that would have sounded extremely German and so inaccurate. All night last night when I tried to fall asleep, which did not take long, I was speaking to myself in my Scottish accent, just trying to retain any of it. It's hard. That Scottish accent, it's kind of like Irish, but then it kind of started coming out a little New York and Italian, and I'm like, I have to go to bed. Yeah. But I was with this English girl. She's so adorable. Her name is Emma. And we were shared a Uber patient about a year in. And I said, do you ever do an American accent? She goes, I haven't. Well, she said it in her brain, but I'll try. And then she's like, oh my God, I'm from America. And I could not stop laughing. She's like, what about you? And I'm like, of course I can do a British accent because I love Downton Abbey. And she was dying laughing with her British friends. It was a lot of fun. It's always a lot of fun when you get to meet other people and, compare notes on the food. Like, no, I did not try haggis, if anybody wants to know. And if you don't know what haggis is, you can look it up and have the pleasure of knowing. And you too will probably never try it. Although I did hear that it was good. It was on my fork. It was prepared to go in. And then I just dumped the fork. I just couldn't do it. No can do. But I did try mushy peas. That's another thing. It's like mushy peas with like mint. It's not my thing. It's not. I tried a parsnip and apple soup. I think the apple was green apple because it was extremely tart and sour. Not my thing. But I love the Chinese food I had when I was there. I was really good. Yeah, I'm not very good with the UK breakfast and UK food. I did have a really good like beef stew that was amazing and a potato soup that was really good. So that I did. But the rest, no. I actually came home and lost 5 pounds. Could be the combination of how many steps I put in every day and the fact that I don't love the food, so I didn't eat a lot. You know, I'll take it. I'll take it. All right. On that note, everybody, so I don't cough your ears off. Don't forget to send the emails and click like, please. Click like and click subscribe and the bell, and then share this because I'm sure somebody will find something that we've talked about today to be very interesting. And I will see you guys then tomorrow night for our live event, and hopefully I will not sound as disgusting. Thank you again, everybody who tuned in and participated, and we'll talk soon. Take care. Bye-bye.